Good morning, everybody. Thanks for attending our hybrid SWOG Survivorship Committee meeting. I hope you'll be patient as we figure out the logistics here. Just a few comments for those attending via the Zoom link. Welcome and thanks for your attendance. We would ask that you stay on mute while listening. If you have questions, please place those into the chat box, and then we will invite you to unmute yourself and ask your question. So we do encourage interaction from everybody, but we also want to make it so that everybody can hear. We also have a surprising number of people here in the room, so thank you all for attending in person. So great to see. And for those who are in person, please make sure you get up and stand at one of the microphones to ask any questions, because those who are on Zoom will only hear you if you speak directly into the microphone. So we'll go ahead and get started. We have a pretty busy agenda for the day. These are the co-chair disclosures. And then we always like to start this meeting by a reminder of the priorities of this committee, which include preventing long-term and lasting effects of cancer treatment, including cardiovascular complications, infertility, understanding of immunotherapy toxicities, and trying to reduce sexual dysfunction. We're also interested in reduction in comorbidity to improve cancer outcomes. This includes exercise and other lifestyle interventions and other behavioral and survivorship interventions. We're also very interested in concepts that will reduce health disparities. We're interested in mHealth and technology in care delivery. And we'd like to expand beyond some of the common cancer diagnoses, which have been heavily studied in the survivorship setting, and also consider metastatic survivorship issues. I'm going to turn it over to Melinda to introduce our speaker today.
Great, thank you. Good morning, everyone. We're delighted to have Dr. Emily Tonarezes as our invited speaker today. She is director of the Office of Cancer Survivorship at the National Cancer Institute. And prior to joining NCI, she was at Memorial Sloan Kettering, where she served as director of the Adult Long-Term Follow-Up Program for Survivors of Childhood and Young Adult Cancers. She earned her medical degree from the University of Rochester School of Medicine, a master's of public health from Johns Hopkins, and she completed internal medicine residency and chief residency at Columbia University Medical Center. We're delighted to hear her vision in regards to cancer survivorship out of the NCI, and hopefully this will stimulate some concepts in our committee that we can move forward. Thank you, Dr. Tonarezes.
Thank you, Melinda, and thank you guys so much for having me. I'm gonna go ahead and start the show. I love hearing your, seeing your slide with the research priorities before I start this discussion, because there is so much overlap between what I'm about to present and what you had in that single slide. So I like to go back to one of the founding fathers of survivorship research, Dan D'Angio, and he wrote in 1975, "It is clear that the child cured of cancer must be followed for life, not so much because late recurrence of disease is feared, as to permit early detection of the delayed consequences of radio and chemotherapy." And in 1996, the Office of Cancer Survivorship was founded with a presidential action. This is actually moments before the founding of the office, when this group of advocates and researchers met in the Oval Office, and President Clinton signed the Yellow Ribbon of Hope. And he afterwards went into the Rose Garden with the group and talked about founding the office in recognition of the large number of individuals surviving cancer for long periods of time and their unique and poorly understood needs. So our mission is to enhance the quality and length of survival of all persons diagnosed with cancer, and to prevent, minimize, or manage adverse effects of cancer and its treatment. And I loved seeing at the bottom of your slide the highlight of metastatic survivorship. And what I'm trying to represent in this drawing is actually maybe a little bit of a new way of thinking about survivorship, or maybe just an evolution of what has happened in survivorship research, which is to say that we recognize that there is that survivorship really can go through different stages. So you can have survivors diagnosed with early stage cancer, or who progress or are diagnosed with advanced or metastatic cancer. And these people, these survivors, have different needs and different goals of care.
About 1:15. Went to Chamber of Commerce meeting.
Okay.
I'll remind you.
They're muted.
Okay. Okay.
Okay, moving on. My immediate predecessor, Deb Mayer, who many of you know, she worked to update our definition of cancer survivor. So we've always said that an individual is considered a cancer survivor from the time of diagnosis through the balance of life. And this is a definition that was taken from the advocacy community and work that had been done even before the founding of OCS. But what Deb Mayer did was to specifically mention that survivors can include those living with cancer and those free of cancer, and that people who are cancer survivors can cycle through periods on or off treatment. And of course, we've had a growing recognition of this population of people who are living with cancer. So this is a paper from Angela Mariotto and others trying to estimate the number of women in the United States who are living with metastatic breast cancer. And we have some new work coming out along these lines, but the idea is obviously that with improvements in treatment and supportive care, also to some extent with improvements in detection of metastatic disease, we see growing populations of people who are living with cancer. So last year, we took a look at what sort of research was being funded in people who are living with cancer. And we really tried to focus on the survivorship research questions, which I'm sure this committee does not need reminding of, but basically the detection and management of side effects, screening and surveillance for second malignant neoplasm, and care coordination and all the issues around healthcare delivery for people who've had cancer. So we took those scientific topics and we took a look at everything that had been funded by the NIH in fiscal year 2020 that was among people living with cancer and that addressed one of those issues. And we excluded things that were specifically about hospice, things that were studies of detecting tumor progression, and studies where the only outcome was survival, because we figured if you were looking only at treatment success or survival among people diagnosed with cancer, that those were really oncology treatment trials and not survivorship research. We found 25 studies, and NCR is funding the most, but actually NINR had quite a number of these studies, and the RO1 was the most common. About half of them were funded through a specific funding announcement, like a PAR or an RO1. And we found a variety of cancer diagnoses represented, including studies which looked at any cancer or any solid tumor. And quite nicely, actually, 72% of these studies were interventional studies. And I just wanted to give you a few titles of what we saw there in this portfolio. So there was a study of acceptance and commitment therapy for fatigue. There was a study promoting resilience and stress management, which is the very well-known PRISM intervention. One about treatment tolerability in older adults with cancer, and that is really a study of managing side effects from treatment. And that we found two studies that were on physical activity in women with metastatic breast cancer. After the portfolio analysis, we held a virtual meeting on survivorship needs. This was a 2-day meeting, and Ryan Knipp, who's a GI med onc, was our keynote address. And the idea with this meeting was really to try to figure out what we know and what we need to know with regards to survivorship in people living with advanced or metastatic cancer. And these are some of the biggest gaps that we found. So I showed you Angela's paper from 2017, but It's actually very difficult to estimate prevalence when you're thinking about cancers besides breast cancer. And even with breast cancer, it's pretty difficult because you have, of course, people in SEER who were diagnosed with metastatic or advanced cancer, but then you have people who progress or people who maybe go through a period without cancer and then have a recurrence, which qualifies them as having metastatic cancer. And finding those people is actually really hard. So you have to try to estimate based on what else is in the literature, what sort of numbers you expect, what proportions of people can be expected to progress or to have a recurrence. And so this is clearly a huge gap, but we need to know how many people are living with advanced and metastatic cancer. We also actually don't know a lot about what this population needs. We heard from advocates during the meetings about problems with care patterns and delivery. Advocates talked a lot about the fact that they show up in different doctors' offices and have to explain themselves. They have to explain the diagnosis that they have, the treatment that they're getting, and sometimes they even have to explain their prognosis to another healthcare professional. And so clearly there are some problems there and some work we have to do. And then even though we found two small, one is an R21 and one was an R01, two small studies of physical activity in women with metastatic breast cancer, we still have a lot of work to do on health behaviors and behavior change in this population. I wanted to tell you a little bit more, and obviously I know you guys are tuned into the topics, the hot topics and the issues that are so pressing in survivorship research, including the metastatic survivorship population. But I just wanted to tell you about some of the other things we're doing, because I think it does highlight, first of all, the ways that survivorship research permeates so many different aspects of healthcare delivery, of epidemiology, of all the different areas of research, and also to highlight some of the things that we're doing that you may not know about that maybe sound interesting to you. So one of the areas that I'm very interested in is the topic of survivors, whether on or off treatment, who show up in emergency room and urgent care settings. And there was this meeting in December, and we're still kind of working through the results of that meeting and the messages that came out of it. But this whole care setting of emergency or urgent care is really understudied. And we know there are huge problems, especially if you have, not especially, but if you can imagine the survivor who is being treated at a cancer center, but lives in a community and shows up at the emergency room, maybe at the community hospital or at an urgent care center that might be an hour away from the place where they're being treated for cancer in an entirely different healthcare system. And somehow that the providers and that location needs to be able to support the survivor who's shown up there for care. And it's a huge challenge and a big gap in our research. I'm also very interested in how cancer survivors are uniquely susceptible to misinformation. And there is some evidence that survivors are more likely to be on the internet looking for information, and that might be one of the reasons that they are exposed to misinformation. But this is a priority across NIH, and these are Francis Collins' words in Nature last year, but really this is a huge gap and a big challenge for people who've been diagnosed with cancer and their families. And some of the evidence that we have is that actually it's friends and family members who are exposed to misinformation, who then bring that misinformation to survivors, and in a perhaps well-meaning way, but maybe misrepresenting the scientific literature to their friends and family members. So there's quite a bit of work to do here also. I just wanted to highlight this work you guys probably know about already, but we are trying to figure out how to promote tobacco cessation in people who've been diagnosed with cancer. This is one method through the cancer centers, but it turns out that people who've been diagnosed with cancer are quite different when it comes to tobacco cessation. And we can talk about some of the reasons that might be true, but this is certainly an area where we have some work to do. It is a different scenario for these people. And it's different also for people who are showing up for lung cancer screening. And we can talk about why that might be the case. I know you guys have already spoken with Lisa Gulicchio and others about this work to try to leverage clinical trial populations. And obviously There are many of your investigators who are doing this work exactly, but this is an ongoing area where we've been instructed, by NCAB and other bodies that we need to figure out how to leverage clinical trial populations for survivorship research. And so this is a big priority for the office and for NCI in general. Financial hardship remains a tremendous problem and an area of active research. HINTS is a national information survey that is coming out with a targeted survivor population. They used a seer-linked survivor sample to ask some questions about information seeking, internet use, COVID-19, health behaviors, and healthcare utilization. And that will be available by request, but it's what, will be freely available once the data is cleaned and ready to use. But it's going to be pretty exciting to have that population-based sample of survivors. I also wanted to mention some of the work, as Melinda told you, my clinical expertise is adults who had pediatric cancer, and we all know, that that's an area of focus for NCI. And one way that we're working on that is through STAR Act-funded healthcare AHRQ technical briefs, and these are the 3 that came out recently. After the last one, which was on disparities, we put out a call for P30 supplements related to organizational barriers that might contribute to disparities in long-term follow-up for childhood cancer survivors. So the questions here are related to policies and procedures from the perspective of the cancer center that make it difficult for survivors to get long-term follow-up care. So this could be the culture, the resources, the teams, the workflow, the space, the staffing expertise, the hours, all of those things that make it hard for people to get connected or to stay in follow-up care at their cancer center. We funded 7. I just wanted to show you the titles of the ones that were funded. Kentucky had examining rural-urban disparities in childhood cancer survivors' barriers. At NYU, they're looking at reproductive health guideline adherence. At Baylor and Texas Children's, they're looking at risk stratification using nurse navigators. At Georgetown, actually, they are partnering with a community hospital to assess the differences in organizational policies and procedures between those 2 locations. At Emory, they have a new support system called IS-SET that they're testing out. At Hopkins, they're looking at neuropsychological assessment. So what's interesting is this one, the NYU on fertility, and this last one, University of Texas MD Anderson, which is on PT and OT, are related to specific survivorship services that might be differentially available to childhood cancer survivors, depending on the organizational factor. So I found that quite interesting when those applications came in, and we have 3 that are kind of on those specific aspects of survivorship care. Following the supplements, we put out a NOC, and I can talk more about, I'm sure you're all quite familiar with the NOC, the idea of the NOC, but I can talk more about it if you're interested. But what we wanted to do with the NOC was to signal our interest, not just in organizational barriers, but also in even larger barriers like system, community, payer, policy level factors that might contribute to differential follow-up or disparities in care and outcomes in childhood cancer survivors. We also are growing as an office. I'm sure many of you know Dr. Michelle Malika. She has been in the healthcare delivery research program for many years, and she's maintaining a secondary appointment there in the outcomes research branch. But she joined OCS as a senior advisor just a few months ago. We also are hosting a monthly director series, and I'll be very interested to hear your guys' ideas about the speakers that we're inviting and what kinds of topics you would like to hear. But the last month, our speaker was Liaisons from UNC, and this was in partnership with NINR, using technology to improve supportive care for cancer survivors and their family caregivers. This month, April, we have Dr. Patty Gans, who I'm sure needs no introduction, and she's going to be talking about revisiting the IOM report on psychosocial health needs for cancer survivors. In May, we have Kyle Orwig from Pittsburgh, who's going to talk about fertility preservation, of course, a topic of tremendous interest for survivors and their families and their providers. And that one is in partnership with NICHD, which is the Child Health and Human Development IC. And finally, I want to end with some words from Ned Sharpless. So I'm sure you all saw the announcement that he is stepping down, and I'm looking forward to working again with Doug Lowy, who is very supportive of survivorship research. But I thought it would be good to just highlight Ned's words from last year about ending cancer as we know it. If we're building a bridge to the future of cancer, what's on the other side of that bridge? A world where we will have changed cancer as we know it. And I think that future is within our reach. Let's focus on a future where all people with cancer have the support and resources needed to navigate their care. Thank you.
Thank you. I love hearing all the various initiatives and interests out of your office. I'm going to encourage people on Zoom to type in any questions or comments into the chat. And then I'm going to invite anyone in the room here to, if they have a question or a comment, to come to the microphone. I have one. I'll start us off with a question. So in regards to the metastatic cancer survivorship, I think where SWOG and the other NCORE sites are very valuable is we can leverage our ability to accrue patients from all over the country in a more rapid approach than at any one individual site. Is NCI interested in any particular cancers, more rare cancers or cancers that are rising in incidence, or any comment in regard to that?
Sure, great question. So we know rare cancers are understudied. The only population where we have any sort of bulk of evidence is the metastatic breast cancer population. And yet they're still understudied. We saw 25 funded studies in all of NIH. So there are huge gaps in the metastatic survivorship, research portfolio, huge gaps. So it's hard to say that anything is well covered. But rare cancers, I think, are fascinating and definitely an area of interest. I also think, obviously, emerging therapies like immunotherapies, and many of these metastatic cancer patients who are living long periods of time are on targeted or immunotherapy. So that would be of interest. I think one of the ways that I feel SWOG could uniquely contribute is related to leveraging those clinical trial populations. And we've seen that immunotherapies are now being used in upfront treatment settings and in the community as well. And we still really have incomplete knowledge of adverse effects, especially longer term for people who've been treated with those agents. So I could go on and on. There are really huge gaps. I think the priorities, when you think about NCI in general, priorities are always going to be understudied areas, but obviously disparities right now are receiving special attention, and for good reason. And so I would always, try to include that in the list of things that we need to get more data on. But it's hard with 25 funded studies. It's hard to say that anything is really particularly well described at this point.
Wonderful, thank you. We'll go to a question in our audience, and then we'll go to our Zoom question.
Dr. Lucas Wong from Baylor Scott and White. Thank you so much for your presentation. Question is, what is the NCI survivorship group trying to reach out to community hospitals or hospitals not affiliated with academic centers or not affiliated with SWOG? Is there consideration of a partnership through SWOG or through academic centers to these non-affiliated hospitals? Because I see lots of cancer survivorship just lost and not studied or analyzed.
Yes. I mean, I would just say I totally agree. One way that we're very actively trying to do that is by working with the Commission on Cancer. Of course, COC covers many more cancer centers than just the NCI designated cancer centers. So that's one way we're trying to do that. But you're absolutely right. I mean, there are so many places, and there's so many places where people are being diagnosed and treated for cancer, where we really do desperately need more research. So I completely agree with you.
Thanks. And now we'll go to a comment and a question from the chat. Benu Symington, do you want to unmute yourself and ask your question?
Sure. I just wanted more clarity. I'm from a rural cancer center, Sweetwater Regional Cancer Center, and you mentioned patients showing up in the emergency room and having to explain their needs. I wasn't sure if you meant patients who were survivors who had a survivorship-related complication, or can you expand on what you were referring to?
Yes, absolutely. So, we consider people a survivor from the time of diagnosis. So certainly during treatment, there are acute events that send someone to the emergency room, which are extremely meaningful with regards to the cancer, treatment itself. And I think, and can be, very difficult to address when you're disconnected from the cancer treatment center, whatever that might be. So, when I think about people who I've seen in the emergency room with cancer, it's very often those visits represent progression of disease, or perhaps necessitating a change in goal of care. And so you have not just the acute event, for example, why is this patient experiencing X, Y, or Z, and not knowing what treatment they've gotten recently, or even where they might have sites of disease. Then in addition to that, you have all of the questions around the fact that now this person is presenting with an adverse event, which may represent progression of disease and may require discussion about goals of care. And yet you have no connection to the treatment team, the oncologist, or even the place where that person was being treated. So I think the issues are actually extremely complex. And as much as we could support maybe medical or surgical management of adverse effects through research and training, or educational opportunities or something like that, there's still so much more to what happens at those times than just managing the event itself, that we really need to we need to figure it out and do a better job of it. So I did go did visit virtually Nebraska and also Kentucky, which are places where people very often live quite far from where they're being treated for cancer. And we talked quite a bit about this issue. So I would say from the NCI perspective, more to come. But if this sounds like an issue that you are uniquely poised to investigate or to figure out how to address, then please reach out to me, and I would love to talk to you, and I can connect you with the NCI group who's focused on emergency and urgent care, and Nanike Shelburne in particular, I would point you to if you're interested. And so, yeah, I feel like there's so much to do, and so I would love to hear from you if that sounds like something.
How would we reach out to you?
Well, you can email me. It's emily.tonorezos@nih.gov. So that's how you spell my name. Or you could go to the OCS website, but it's just my first name dot last name @nih.gov. Yeah, I would love to speak.
Thank you. Thank you.
Any other questions? So I wanted to make a comment. Thank you, Dr. Tonorezos. It was really great to see that your priorities are very closely aligned with ours, including what you were mentioning about the need to leverage our clinical trial populations to address long-term survivorship issues is actually something we spent a fair amount of time yesterday at our NCORT meeting discussing, and have on the agenda for the end of this meeting today. And so we'll look forward to thoughts from our committee members on how we can best do this. We've made some attempts in the past, and we are planning on putting a committee together to look at going forward how we can better engage our survivors who have participated in clinical trials with SWOG. And actually some offline, very interesting discussions have developed already just in the past 12 hours or so. So
Amazing.
We hope to share some ideas with you in the future.
I mean, I assume Dawn is in the audience or on the call or something. Yeah. So, I mean, obviously I point all the time to the work that she and you guys have done with regards to survivorship in clinical trial populations. And I think that in the model of the investigator-initiated study, or that where you have a specific question that perhaps can be answered by looking at a clinical trial or a combination of trials, I think that is one way to leverage clinical trials, and obviously a very important way. I think we should, I hope some of what you guys are discussing is also what are the ways we could facilitate this as in a larger way, so because that's some of what we're trying to do. And if you want, I'm sure Lisa Galicchio would come back and meet with you guys whenever you're ready for her, to talk from the NCI perspective as well.
So this is Dawn. So I was just going to say that, yes, there's opportunities to do retrospective research, and it's always interesting and hypothesis generating, but we have the opportunity to do prospective studies that, because we have this incredible network that touch on all of the things that you mentioned. And I think it's like ripe for us to, ask some of these important questions, get funding to do. And what some of the groups have done, some of the committees have done, is just say, like, we want to get the best idea. So we're going to ask everybody to submit a 1-page idea of a study that they have, and then pick the best one to try to move forward, or the best 2 to try to move forward, to stimulate ideas of how to capture this patient population and ask the best questions, in our network.
Amazing. Great.
There's a couple more comments, one in the audience, and then we'll go to Bernard Parker on Zoom.
Hi, good morning, everyone. I'm Pelty Dillon, and I'm on the lymphoma committee as patient advocate. And this was great. Thanks, Emily. I just to follow on with what Dawn just said, I think, being very involved in how our advocates review informed consent. Right now in our trials, of course, people have to consent to ongoing research and translational medicine for the samples collected during their study. Why not ask them if they want to participate in long-term follow-up and survivorship studies? And then we can build a mechanism either, through technology to stay in touch with them. And as the ideas generate and the concepts come to fruition, we would have a pool of people that have opted in and provided contact information. But, people do move, but with cell phone technology today, people's phone numbers generally stay the same regardless of where they are in the world. So I think that we're sitting on a really ripe opportunity here.
Wonderful. Thank you. Yes, that was discussed last night. And then how things are different nowadays with central IRBs and being able to recontact patients. It's a little bit more streamlined or easier now than it was 5, 10, 20 years ago. So we look forward to really moving this forward. And then Dr. Parker on Zoom, if you want to unmute.
Hello. Yes, this is Bernard Parker. You can call me Bernie. That's fine. I was called Bernie as a teenager. So, but just wanted to say thank you so much for this presentation. Wanted to mention that I placed into the chat that about the fact that primary care providers are pretty essential when it comes down to survivorship, and I think that there's a challenge that many primary care providers may not feel comfortable following up with patients who are survivors because of the long-term impact from, say, chemotherapy, radiation therapy, things like that. So they're not fully informed about how to follow up with the long-term effects. So I really appreciated your slide there that you showed of the emergency situations, the urgent and emergency situations, because not just for patients that are on active treatment that can come, that doctors will come across in the primary setting. After all, many patients with cancer have other conditions, just non-oncologic conditions that are being followed by their primary care providers. And so the treatments, when on active treatment, can exacerbate some of those conditions. But then after treatment, days, weeks, months, years later, complications can occur due to the long-term effects from things like radiation therapy and some of the other treatments. And now we also have the new armamentaria, which include the immune checkpoint inhibitors and CAR T treatments and things of that nature. So I really appreciated that slide and in regards to cancer survivorship. Thank you very much.
Okay, wonderful. Thank you, Dr. Tonorezos, and we look forward to continuing this discussion with you. And thank you so much for participating in our meeting. You're welcome to stay on and hear some of the concepts that we have that are active or proposed, but we also understand, I think, that you're at AACR, and if you have to hop off, we understand that as well.
Thank you. About to leave for AACR. So if any of you end up there or you're attending virtually, you can also find me in the AACR attendee thing, and we can chat or have a meeting in New Orleans if you'd like. Thank you.
Thank you so much.
Bye.
Great, thank you.
Okay, so I think we'll now turn it over to our amazing patient advocate, Dr. Yes, you've been elevated to Dr. To Lee Jones.
Okay, thanks, Melinda. This last presentation really raised a lot of thoughts in my mind that I hadn't been planning to address. I was a speaker at that 2021 metastatic survivorship conference that Dr. Tonorezos mentioned. And one of the things we need to remember is that there are survivors who are living with metastatic disease, and there are survivors who have actually gone through their treatment and are no longer have any sign of cancer. So unfortunately, I'm one of the latter ones. So there, again, like everything else, there are several categories of metastatic survivors, and we need to make sure we don't lump them all into the same basket, because they really, I learned a lot from my two panel members who were living with metastatic disease compared to what I'm doing, which basically I'm just living my life as if I'd never had stage 4 colon cancer. But again, I'm very, very fortunate. So I'd like to thank Dr. Tonorezos for all she does to help cancer survivors in the US. I was at a policy briefing for the National Coalition for Cancer Survivorship just last week. Dr. Sharpless was one of the speakers. He mentioned it's one of the few times he's actually spoken in person. I think it was the day before he announced his resignation. So I don't know, maybe we drove him out of NCI. I don't think so, but it was interesting. So it happened so closely, but there are a couple of things that he had mentioned that I wanted to bring up here. So he talked about the amazing growth of survivorship grants for NCI. Back in 1998, there were 13 grants for a total of $3.2 million. In 2020, there were 165 grants for a total of $111.6 million. So what occurred to me was, well, gee, how much of that money is SWOG getting? And I guess S1820 was something that probably would be included in that 2020 number. But I would like to see us getting at least our fair share of that money, perhaps more. One of the other things he mentioned was this concept of pay lines, which from NCI speak is what percent of proposals are actually funded. And he mentioned that 11% for experienced researchers are being funded today, but 16% for young investigators. So I think that's really a clear message that we ought to be making sure that we get our young investigators involved in submitting proposals for NCI grants, because they have a much better chance of getting funded than us old timers might. So some of the things that he had mentioned in terms of what they were funding, so not unexpectedly, breast cancer and physical activity survivorship grants were the most funded, but also something they called usual care. I'm not sure exactly what that refers to. Prostate cancer, long-term survival, which is something that Emily talked about. African Americans, genetic services, cognitive training, neuropathy, and ovarian cancer at various levels. So we can be thinking about certainly any of those categories because they've received a lot of funding, but also categories that have not received much funding. Also, as Emily had mentioned, new areas that they're interested in funding for, like metastatic. So yesterday, Dr. Blanke met with the Patient Advocate Committee and talked a lot about SWOG's commitment to diversity, equity, and inclusion. So I wanted to point out that for those of you in person, in your bags of goodies, you would have received a couple of items. One's a field guide, and then there's a sheet here talking about the things that we can do and we should be doing to improve the diversity of our clinical trial participants throughout SWOG. And yeah, there are lots of issues related to that. I mean, first of all, we don't have a lot of control over it. It really is through the research sites, and we go through the NCORP sites to get access to those patients. But there are things we can be doing, we need to be doing. I know at a SWOG level, there's a lot of activity going on. There are DEI champions for 5 of the organ-based committees. We don't have one assigned to us, so we have to be our own champions. And I think that's something that we can pretty easily do. One other thing I just wanted to mention is that I'm involved in working on the Virginia State Cancer Plan, and every state has a cancer plan, and every cancer plan does or should have a section on survivorship. And I think it behooves all of us to get involved in that process to make sure that survivorship is really well represented. I think in Virginia's plan, there's a woman from the Department of Public Health, and there's me, and those are the 2 people involved in survivorship. For palliative care, there are a couple of palliative care doctors who are involved in it, so they're going to get a lot more attention to that part of the plan. So especially doctors interested in survivorship, contact your state. I guess every state does have a nonprofit group that is funded through the CDC for these kinds of activities. And I'd like to see us all getting involved in that to make sure that survivors are well represented at the state level, because that's where a lot of activity really happens. And I think with that, I will stop. But thank you very much for being here, both in person and virtually.
Thanks, Lee. Okay, so I just wanted to mention about a COG special session that happened on Tuesday. While I do that, it's hard for us to see who is online, and even with masking, hard to see who's here in the audience. So if any of our committee liaisons who will speak after I do have updates to share, I would appreciate if you could put that in the chat, and that includes our cardiotoxicity panel. If anybody is online, please make note in the chat so that we can call on you. And if you're here in the audience, maybe make your way up to the microphone. And we'd appreciate updates from any of our committee liaisons. And while you do that, I just wanted to share that the Children's Oncology Group is also having their meeting this week, and they hosted a joint session with all of the clinical trial groups, looking at ways to participate in trials, in NCORP trials across all of the networks in the AYA population. There's going to be a little bit of a continuation of that, I think, at the AYA meeting later this week, or I think it's tomorrow. And Dr. Salzman is going to be speaking at that. But anybody who's interested in AYA survivorship issues, there was a big group that was very interested in looking at how these studies can be conducted across the network and including the Children's Oncology Group. All right, so we have one, we have our radiation oncology liaison, Dr. Carrie Cook, if you'd like to unmute and share with us any updates that you may have.
Hi there, Carrie Cook from OHSU. Well, our SWOG meeting isn't until Saturday, so I don't have any particular meeting updates yet, but I just, you know, in listening to the meeting so far, just wanted to kind of share some thoughts about areas for collaboration from Dr. Tonarezos' talk. I mean, health disparities is, you know, with radiation oncology, it's a ripe area for research. You guys mentioned people being far from centers, and I think it's even harder to get to radiation oncology centers sometimes, and often those centers may not have the same types of treatment. For example, SBRT that we use for oligometastatic disease, you know, which is an area of focus that she mentioned as well. And the misinformation initiative that she mentioned is a challenge with us as well. You know, radiation is just historically a tough thing for some patients to get their mind around. And, you know, if you Google it, there's a lot of pretty bad stuff out there. So patient education is a good area for collaboration as well. Additionally, there's a number of radiation related studies within SWOG focusing on de-escalation of treatment in sites like GU, GI, breast, and there could be areas for you know, long-term follow-up of those patients, how it impacts survivorship. So feel free to reach out if you'd like me to facilitate any of those collaborations.
That's great. And I hope you will share back at your committee meeting some of the interests that the Survivorship Committee has in terms of late effects, and make sure that some of these ideas get incorporated into the therapeutic trials.
Absolutely. Got a lot of notes here.
Great.
Okay, if there aren't any additional, wait, one more comment or yes.
Peter Van Veldhuizen. I don't have a lot of updates. I just wanted to comment. There is a study in the queue that's probably a year away or so, looking at small renal masses, biopsy or no biopsy. That's kind of primed to have a survivorship component. So if there's anybody that's interested in looking at that patient population, I just wanted to call
So
out.
can you explain the study a little bit more?
So patients with small renal masses are often just followed expectantly. In this study, they're looking at the role of biopsy, related to biopsy or not biopsy, and then they'll be followed over presumably a long period of time. And I think really looking at the role of biopsy in that setting. And then I think there's going to be a imaging component, but it'll be a patient that's captured for a fairly long period of time, and one could look at other things survivorship wise as well.
That's great. Thank you.
So any ideas?
Yeah, it's Dawn again. I would just sort of say that there are a lot of therapeutic trials for patients with newly diagnosed advanced metastatic cancer across the spectrum, as well as the cohort study that's being done for looking at toxicities from IO therapies, and that sometimes the studies that are ongoing, it's a rich resource to think about sub-studies or things that could be added on to understand the experience of metastatic cancer survivors a little bit better, to inform, you know, an interventional trial in the future, but just to also help us understand the experience better. So sometimes taking advantage of some of those cohorts may be a good opportunity as well.
John Hickstrom here. I'm one of the liaisons from the surgery committee, as well as also from melanoma. And I just wanted to follow up on that. And I believe Katie Tsai is working on pushing through a study looking at IO effects on fertility for patients in the advanced metastatic setting. I think it's going to be a bigger issue for adjuvant care for melanoma in particular moving forward. So those are areas of cross collaboration. And then from the surgery side, I can tell you that in melanoma, there's a study opening looking at surgical margins and quality of life related to surgical margins and resections and repair. And so also an area of particular interest to earlier stage melanoma patients. One last thing is also patients treated with axillary or inguinal dissections, both for melanoma and breast cancer, suffer from lymphedema. And there's many survivorship issues that could be explored in terms of lymphedema prevention surgery efforts as well. So just wanted to give you those updates. We don't have our meetings until tomorrow, so we'll follow up next time.
Great, thank you.
Okay, wonderful. Thank you. I love the engagement in person and online. So this is just wonderful. I think we will now switch it over to our active trials and studies or concepts that are in development. So hopefully Justin or Monica is on Zoom and we will advance your slides for you. So just say next slide, but unmute and you can begin.
Can you hear me?
Yes.
All right, I'm not sure. Monica, are you on? All right, well, it looks like I'm presenting. So thanks everyone for letting us have a couple minutes. I'll try to keep this very brief. You've heard about 1501 for quite a few years, but give you an update where we're at and then leave room for questions. So I think really most of you know the schema by now. This is a trial looking at reducing the risk of cardiac dysfunction and metastatic HER2 overexpressing breast cancer patients. It was a 3-arm trial looking at carvedilol versus no intervention in men or women with metastatic HER2 positive breast cancer who are at high risk for cardiac dysfunction. We've closed the 3rd arm, non-randomized arm of the trial as it's met accrual. Patients are still being accrued to the intervention arm. They're assessed every 3 months with echocardiograms for cardiac dysfunction, which is a change in ejection fraction. As you can see, there's several secondary endpoints that we're looking at, which we've discussed before. Let's move on to the next slide. So briefly, patient population, who are we looking for? If you don't have the study or you have the study open and aren't accruing to it, this is who we're looking for. We're looking for patients with, very simply, metastatic breast cancer. They need to be starting or continuing on trastuzumab-based HER2 targeted therapy. There's been several amendments go through, and now we allow up to 4 lines of prior therapy. We've amended the protocol to add, really, I think, all of the new HER2 targeted drugs, as there's been several of them added that are trastuzumab based and would qualify for acceptable regimens for the trial. Additionally, there's been a lot of question back and forth over the past several years about biosimilars. We've accepted those from the beginning, but there's an amendment in now that has that in writing for everyone. So biosimilars are accepted, and additionally, patients with brain mets are allowed. In addition to patients having metastatic breast cancer receiving the above described therapy, patients need to have a high-risk feature for cardiac dysfunction, and that's defined as one of the following: prior anthracycline use or exposure, a borderline ejection fraction on their baseline echo of 50 to 54%, age greater than equal to 65, a BMI greater than equal to 30, on current and or prior antihypertensive therapy, coronary artery disease, AFib, flutter, or diabetes. So just one of those plus metastatic breast cancer receiving some sort of trastuzumab-based HER2 targeted therapy. Our accrual has slowed because of our intervention being carvedilol. Many patients are on either an ACE or a beta blocker. So that does limit your patient population a little bit. As far as requirements for startup, if you don't have the study open, we are actively looking for new sites, meeting with other groups, trying to encourage new sites to join. Section 13 of the protocol will tell you how to get the study started, but essentially the first step is to validate your echo lab, which requires 2 echoes to be sent, de-identified via this mechanism called AG MedNet to Monica at University of Michigan for interpretation. Once that's done, your echo lab, once that's successfully done, I should say, your echo lab is credentialed or validated. There's further resource available for this for the sites on CTSU. We have 168 validated labs, 151 CTSU approved sites. 118 of those are SWOG sites. Next slide. And how are we doing? Here's a list of the top accruing sites. So as you can see, there's been some sites that have accrued very robustly. City of Hope has put 43 patients on the trial. And there's a list of other sites that have been very active accruers. We've accrued 265 patients thus far. Years gone by before the pandemic, we were up as high as 10 to 13 patients a month. COVID hit, cancer control accrual slowed dramatically. And now that we've closed our control arm, or not control arm, the third arm of the trial that allowed patients on an ACE or beta blocker, our trial accrual has slowed more. So we have made some modifications to the study as stated previously, hoping to improve accrual. We've met with the Alliance recently. We've established Dr. Ruddy of the Alliance Symptom Control Committee as an Alliance champion, hoping to improve accrual through that group. I've emailed the breast chairs of the Alliance, and Monica and I are going to try to present to the Alliance Breast Committee and do the same thing with each of the other cooperative groups respectively to try to garner support from each of the groups and see if we can get accrual picked up. There's a lot of other stuff I can talk about that we're doing to boost accrual, but I'll save that unless there's questions on it. Our neuregulin levels at baseline, which was one of our translational aims, have been assessed, and we're starting evaluation of those, correlating them to some baseline clinical factors, which is exciting. So check and see if it's open at your site. If not, open it. There's an email there letting you know how to get in touch with us. We are actively looking for sites. And the last slide is the funding memo, just so you know, dollars and cents of the study. People often ask this. Especially it comes up on the breast committee when you're talking about treatment versus cancer control trials. Sometimes it seems as if there's a misconception that there's not funding for the trial, but there is, and there is a copy of the funding memo. So that was quick. I'll stop and take any questions that you may have. Thanks again for allowing us to present.
Thank you, Justin. We have a question or comment from Don Hirschman.
So sometimes we say, don't let perfect be the enemy of good. And sometimes when you end up in this situation where there's a trial that has, I don't know, you're about a third, a little less than that, accrued, a quarter accrued. Sometimes it's a good time, actually, as time has passed, to go back and look at the stats section and to say, like, okay, could we change our goals? Could we change our endpoint? Can we change our expectations about what we can get in a shorter period of time to try to lower that sample size to, end in the century? So I think it might be worthwhile, I don't know, you know, as I'm sitting here next to, you know, statistician, you know, like to sit back and take a look at the protocol and what you have and think if any modifications can be made to change the goal.
Thanks, Don. I appreciate that comment. I think that's timely. And Amy Darkey is our statistician. We discussed this recently, and we'll put it on the agenda for our next monthly meeting. We meet once a month. And, you know, because of the non-randomized versus randomized patients, you know, really what we're looking at for statistical analysis would be mainly the randomized patients. And I think we only have about 125 of those patients. And so the other 140 or whatever was the third arm of the trial. So there wasn't a huge amount of power there to make conclusions, but I still think it's a good question. And it's a good question because I'm sure we're going to be asked that anyways. So it's a good exercise to go through. So thanks. And we'll continue to look at that.
There's another question or comment from the audience here.
Hi, good morning. I'm Javier Retamales from Chile. We have 2 sites there, and a barrier that some cardiologists have said was about there are some patients that they really don't have a good window, ultrasound window for the echocardiography. So what about including MRI for evaluating those patients? Because for some patients with tissues expander after mastectomy or with radiotherapy or obese patients, having that ultrasound window can be very difficult. Can we use MRI in the future? What do you think about it?
I think it's a good question, and I understand the question. You're right. There are times when echo just can't be done because the windows aren't there. It's not the majority, but it does happen. And I'll circle back with Monica and the cardiology folks, but since the primary endpoint is actually a change in ejection fraction based on assessment via echo, I think it would weaken the significance of our endpoint if we allowed other modalities in to assess it. But I would defer to Monica and the cardiology folks to weigh in on that for sure. So I'll put it on the agenda to rediscuss at our next meeting. I think it's a good question. Thank you.
Another comment from Kathy Krieg.
Hi, this is Kathy. And do you have any data in terms of the main reasons why patients aren't eligible to participate? Is it because they're already on a beta blocker or because they've had too many lines of HER2 targeted therapies? So knowing the main reasons for exclusion might help you in terms of, potentially broadening your eligibility criteria. And I guess if you have some, I know that the echoes are being interpreted centrally. So if you have some baseline data from even your observational cohort who may already be on ACE inhibitors and beta blockers, maybe you can use that information to then inform if you do need to redo the power calculations of like, what's the potential effect size that you're going to see in your study.
Thanks. I think I really still feel like the big issue in accruing, I think there is obviously the issue of the ACE inhibitor and the beta blocker. I think those are going to be the 2 biggest criteria that keep people off the trial that otherwise would be interested, because in the population that are at high risk, and we knew this designing the trial, there's going to be a significant portion of them that are on an ACE or a beta blocker. But as you look at the accrual across the different sites, I really still feel like, it can be overcome. It's just where there's a real, champion and interest, if you will, in doing it. I think the patients are out there. I think it just is, an issue of getting more, if we can get more sites that are actively engaged because we have demonstrated that sites that are really actively engaged in screening patients for it can find patients. So I think it's probably a combination of, recruiting sites and, to your point, probably the medications as limiting potential eligible patients, but we'll relook at that as well. I'm taking notes.
Wonderful. Thank you, Justin. I think in your most recent letter sent to the sites, you recommended if each site could just accrue 1 or 2 or 3 more, then you would be a lot further along in your recruitment goals. So we encourage all the sites to put maybe just a little attention in the screening to try to accrue a couple more per site.
Yeah, it's amazing, truly, of the sites, and I don't have the numbers right off the top of my head, but of the number of sites that are actually have the trial open, how few of the sites have actually accrued all those patients. So yeah, so if we did just send out a letter clean for people to really screen for it. So we'll see what happens. And we have a few other things that we're doing in the background as well. But thank you all for your suggestions. We'll review them. Really appreciate it.
Yeah, no, I was just going to say the same thing, that the hard part is getting that echo validated. And then once that's done, it's not that hard to identify patients that are potentially eligible. So, yeah, I think.
I would agree.
So if you
thank you
have it
very
open at
much. I
your
really
site-
appreciate it. Thanks to all for your patience.
And Justin, there are some additional comments in the chat if you want to take a moment and look at them and maybe respond via chat.
Sure, we'll do it.
All right, so I think we're going to move on to our next presentation. If I can get the remote to work. Dr. Raz or Dr. Sun, would you be able to discuss S2204, the perioperative physical activity intervention in older adults with lung cancer and their family caregivers?
I'm here. Hi, it's Dan Raz. Thank you so much for having me. I'm sorry I can't attend in person. This is our study concept, S2204. It involves a personalized physical activity intervention for older adults who will be undergoing lung cancer surgery, and it also includes their family caregivers. And just to provide you some background, you all know that the population of older adults with cancer is growing, and lung cancer surgery is one of the more common cancer surgeries that we do. Lung cancer surgery is unique because oftentimes people have impaired respiratory function or breathing due to cigarette smoking if they used to smoke or currently smoke. And in general, older adults have a range of physical frailty, a range of medical problems. There is a lot of pressure for early discharge. I'm at City of Hope. I'm a thoracic surgeon, and our average length of stay is only about 2 days. And sometimes we even discharge patients the day after their surgery. And so, what happens is there is less time to work with patients. The stress and burden of caregiving is amplified in family caregivers. Oftentimes, these older adults have family caregivers who are not in good health and are frail themselves. Sometimes, and very oftentimes, they live alone and have, this creates a very stressful situation for family caregivers. So addressing the needs of family caregivers is also really important. And so in designing this intervention, we looked at some of the critical gaps with respect to physical activity and recovery from lung surgery. First of all, very few interventions are actually grounded in evidence-based behavior change and self-management principles. And we feel that this is really important because the benefits of exercise extend far beyond just the perioperative period. I tell patients often, who are asking, what can I do to minimize the chance of cancer coming back? What can I do to improve my quality of life long term? And walking is always part of that answer. Very few physical activity interventions have a personalized approach. And really none in the lung cancer space leverage family caregivers, and data has shown that this is really of critical importance. And probably most important is the lack of attention to access and scalability. And what I mean by that is that there have already been a number of physical intervention studies in lung cancer, but they've all been single site studies that tend to be very resource intensive. So, daily or several times a week in-person physical therapy, sometimes many weeks before undergoing surgery. And that's just not feasible in many healthcare settings. And so we are proposing a telephone-based intervention that's centralized, and we really focused on scalability, on feasibility, so that this can be implemented in a variety of healthcare settings. Next slide. I want to actually skip to the study schema. If we can you advance a couple more slides till the schema? And I can talk, keep going. Mm-hmm. I'll address all of these with the schema. I think it'll just be simpler. One more, I think. Okay, perfect. So this is the study schema. So our study is a randomized trial. This is for lung cancer patients who are 65 years and older, who are scheduled for lung cancer surgery. They have to be at least 7 to 14 days pre-op, so relatively short period. And that's because in many places surgery is scheduled 2 weeks, sometimes usually a little bit longer, but can oftentimes be scheduled just a week or two after the patient is seen. And so we want to be able to accommodate for that. The patients have to be, sorry, this is not updated, English or Spanish speaking. So it's both English and Spanish speaking. And family caregivers are identified by the patients, have to be over 18 years old and also English or Spanish speaking. Patients who do not have a family caregiver can be enrolled. It's strongly encouraged, but we will still enroll patients who do not have a family caregiver. The patients undergo a baseline assessment, which includes a geriatric assessment and a 6-minute walk test, which is the main endpoint of this, as well as the SPPB. And then patients are randomized. We stratify based on surgical approach, meaning whether they have an open or minimally invasive surgery, age greater than or less than 80 years old, and frailty index. And then the intervention arm receives a personalized walking program that includes 5 telephone coaching calls. There are elements of behavior change principles that we incorporate in order to coach the patients. The personalized walking program also includes simple lower extremity exercise. And then the family caregivers are also included and coached to be walking buddies and also to help to motivate the patients themselves. The patients and family caregivers also get an intervention resource manual, and the patient gets a VivoFit 4, which is a pedometer that they use for self-monitoring. In the control arm, so we applied for an R1 as well as a PCORI, so actually the controls are slightly different in both. This is what we propose in the R1. They get ASCO's Cancer Survivorship booklet, and then they get telephone calls from a study RN. So in the intervention arm, all of the interventions are done by physical therapy and occupational therapists who are trained for this. In the attention control, these are calls from an RN to discuss the Cancer Survivorship booklet, and they also get a VivoFit 4. You can see the timing of the coaching calls are 1 before surgery, then days 7, 14, 21, and 51 after discharge. And then there is a discharge assessment, and then a 30-day and 60-day assessment. The assessments that need to be done in person are the 6-minute walk test. We don't have a great way, and the SPPB. We don't have a great way of doing that via telephone yet. And then there are a variety of surveys regarding health-related quality of life. We also look at time at home, surgical outcomes, including readmissions and complications, especially pulmonary complications. That's the one kind of area that we're most can be affected by perioperative exercise intervention. And then we also look at perioperative sarcopenia. So we're looking at patients' CT scans before surgery and measuring muscle volume to determine how relative sarcopenia can affect the outcomes. And then we also are exploring what we call digital biomarkers of aging, which are daily steps. These are all pedometer-based endpoints. We can look at things like daily steps, sleep, and other kind of functional assessments based on that will be an exploratory endpoint. Next slide. So as I mentioned, we submitted a PCORI Healthy Aging grant proposal in January. We should be hearing at least a preliminary sometime, I believe, in May. And then we also submitted an R01 in the February cycle. Next slide. And I previously, in our previous meetings, we presented kind of the milestones, but I really want to show this really to thank everyone who's been involved in developing this concept to the point where we are now, particularly Melinda and Hallie and Taj, and of course, Virginia has been incredible. Thank you, Virginia, for being such a wonderful partner in this. And I also want to mention, I didn't include a slide, but we already have, I believe, 11 different sites who have kind of confirmed participation in really diverse populations in the United States, both in academic as well as community-based centers that have experience accruing with SWOG studies. And so we're really excited, and it seems like we've had really wonderful support throughout this whole process, and a lot of surgeons are really excited to accrue to the study. Hopefully we'll get funding quickly, and I'll turn it back over for questions.
Great. Thank you so much, Dan. Any questions on chat or in the audience? Please come forward. I have two questions. I'm thinking about, the previous trial we just heard about from Justin, and making sure we don't have any barriers to enrolling participants, because it's such an important study. And the only concern I have is the 6-minute walk test at the various sites. And if that becomes a barrier, whether there's a way to have the physical activity, the steps walked, as an endpoint, because it's better to get someone enrolled with maybe not all the data rather than excluding because they can't do the 6-minute walk test at their site. Thoughts on that?
I think that's a great thought. It's hard in terms of the actual data that we get with the pedometers, because 6-minute walk test is such a well-established metric. We have kind of a sense of like what's a meaningful change in 6-minute walk test. It's been used, in most of the physical activity studies, at least with respect to lung cancer surgery. So I think that's a really important thing that we should talk about. And the other thing we've been exploring is, whether we can do a 6-minute walk test somehow virtually, with the patient at home. And so I'll talk more with Virginia about those. I think that's a really important suggestion, because I agree with you. That's always, the one part that we're a little bit nervous is we still have to do that assessment at 30 and 60 days.
Okay, thank you. A comment from the audience?
Hi, this is Kate Castro from the NCI, and I just wanted to add that the Alliance currently has a preoperative study called OptiSurge, which is being done in patients older than the age of 70. It includes GI, major GI surgeries and lung. So that's about half done with its accrual. Dr. George Chang from MD Anderson is the PI leading that effort. So I would encourage you to talk to them at the Alliance and maybe some lessons learned for how to move forward, and maybe some of the practices that are doing the thoracic side of that study might be someone interested in continuing on this work when this gets funded.
Yeah, thank you. I know George well, so I'll reach out to him. I've heard about the study. There's some differences, but yeah, thank you. I'll definitely check in with him.
Great, thank you. And Melinda has another, did you have another question?
Yes.
Melinda?
So in a trial that I did that was telephone based, we realized in COVID that, so many of our study participants learned how to do Zoom. And so now many of them preferred the Zoom based counseling call. So you might want to think about that too when funded and initiating this, especially if you can do the 6-minute walk test virtually. But it might, I don't know if there's been any trial head-to-head comparing telephone versus a Zoom platform, but if you think you might get better engagement and therefore an increase in walking via Zoom, by seeing the participants, that might be something to consider as well.
Yeah, no, I think that's a great suggestion. I know, we have experience doing centralized interventions via telephone. I like seeing people face to face, but we also have a lot of patients who have technical difficulties, especially older adults, and it can be, we were just concerned about feasibility, and resources when there are technical issues. But I do agree it would be great to have televideo.
Yeah, and there's a comment in the chat saying, as a site in a tech dead zone, it would be great to have the option of in-person as well as virtual assessments.
Yeah, fortunately, almost everyone has access to telephone, whether it's a landline or a cell phone. So, that tends to be a pretty reliable way of getting in touch with people.
And then Vicky has a great comment that maybe you can respond to in the chat, but
Yeah,
by adding more objective clinical endpoints,
Yes.
maybe from CT scans, that could strengthen the clinical relevance perhaps too.
Yeah, Vicky, I'll respond to you in the chat.
Okay, thanks.
Hi, and it's Marie Bakaitis from the University of Alabama at Birmingham and also the co-chair of the Palliative and End of Life Committee. I'm just going to echo what's being said in the chat and by others. Being in Alabama and Mississippi, where most of it is a broadband dead zone still, despite attempts to make it better, and the numerous studies that we're doing with colleagues across the country that are comparing, Zoom or, internet-based versus either live or telephone. The internet-based has been a miserable failure. And we always seem to have to resort, and I'll say always, almost always have to resort to either telephone or, in person is often not an issue. So landlines still reign supreme, unfortunately, in a lot of the South. And so I encourage you to keep that as an option, and we will definitely create more disparities and leave people out when we are relying solely on internet-based interventions.
Thank you.
Great. Any other questions about this study?
Well, fingers crossed that you hear good news from NCI or PCORI.
Thank you very much.
Thank you.
Okay, and then I'd like to invite, I think Dr. Gunteru is up next to discuss her active trial S2013, which is actually primarily being developed in the Symptom and Quality of Life Committee, but developed in this committee as well. Dr. Gunteru.
Thank you very much. So I have presented S2013 in the early stages, so wanted to give you an update and ask other sites to open the study. So the why behind S2013 is to give more information to clinicians to better care for our patients and also for our increasing quality of life for our patients who are undergoing immune checkpoint inhibitor therapy by identifying who is at risk for developing these immune-related adverse events. So this overall schema, let's say once patients are consented and registered, these are people who are getting immune checkpoint inhibitors for any solid tumor, whether it's adjuvant, neoadjuvant, or metastatic, would be eligible to go on the study as long as they're receiving only immune checkpoint inhibitors and no chemotherapy or biologic therapy or targeted therapy along with immune checkpoint inhibitors. There are 5 time points for the evaluation. One is at baseline and other 4 is when they are on treatments. So there is no other treatment is in this study other than what the clinicians, the oncologists are giving as a standard of care treatment. When they develop grade 3 or higher immune-related adverse events, then there is another evaluation that happens. The total study timeline is for 1 year, and that would conclude the trial participation, or unless there is a death that is earlier. Next slide, please. What we're looking at as the primary objective is to develop and validate a risk prediction model in the same study for CTCAE grade 3 or higher non-hematological immune-related adverse events. Again, this is in the first year of immune checkpoint inhibitor therapy for any solid tumor. Next slide, please. We're also looking at lower grade and non-hematological grade 2 toxicities to assess the incidence of these immune-related adverse events. The important part of this study is getting patient-reported quality of life and patient-reported adverse events to aid in the clinical summary of these patients. We're looking at patterns of treatment of these immune-related adverse events and toxicity over time. Next slide, please. So our goal is 2,062 patients, and currently we have 190 patients that are enrolled from all the sites. I would like to thank all the sites who are already opening and enrolling, and would like to ask others to consider opening this trial at your institution. Next slide, please. I'll go over the calendar, study calendar. As I said, this is a standard treatment from the oncologist, so no drug provided by the study. They would be getting baseline studies, labs and scans and everything for the treating oncologist. So at pre-registration, they would undergo their further evaluation and CTCAE toxicity assessment. At that time, they would also report like the patient-reported outcomes. They can elect at that time whether to do paper or EPRO for follow-up at pre-registration time. And at that time, they would also get the blood test, and we ask for tissue for banking if it is available. So once they start immune checkpoint inhibitors at these 4 time points, week 4, 12, 24, and 52, we'd be evaluating again with the CTCAE, PROs, and if they develop any IRAEs, immune-related adverse events, in between, then we ask the sites to report those too. So there is another blood test that would be at week 4, and if they develop any grade 3 or higher immune-related adverse events, we would get another blood test at that time, along with the CTCAE toxicity and also the IRAE form. Next slide, please. So the translational objectives of this study is looking at a cytox score, which is 11 different cytokine levels, both prior to immune checkpoint therapy and after 1 cycle, to see if there is a predictive signature for the development of these immune-related adverse events. This is going to be a huge biorepository for future studies because we're going to get archival tissue in many of these patients and also blood or plasma specimens too. which will aid in our understanding of immune-related adverse events in the potential future. Next slide, please. I would like to thank our S2013 team, our Symptom Control Quality of Life Committee chairs, and our Survivorship Committee chairs in supporting this study, and for all of our patients and staff sites for enrolling and opening this study, and for people who are thinking about opening too. Thank you.
Thank you. Any questions about this?
Dawn?
Yeah, so I just wanted to let people know there is another trial that's being done out of URCC that is somewhat similar. I can't remember the name of it, Krishna, but if you have it on hand, but patients can go on both if they're willing to do all of the assessments. So people may see, you know, theirs is really focused on a disparities related issue, I think, in terms of development of adverse events. But it is possible. It's just a lot of assessments. But if a patient's willing to do it, they are allowed to go on both. And the last thing I wanted to say is that if people do have ideas of secondary studies, please reach out to Krishna. I know something came up in digital engagement about looking at, you know, more biometric assessments in terms of prediction of toxicity, which could be an interesting sub-study. But if ideas come up about, you know, it would be a good, like Hope Foundation funding might be a good source to do a sub-study on this. I think we have about 150 patients-ish enrolled at this point, but it's out of 2,000. So there's still time if you do it quickly.
Great, thank you.
Thank you, Dawn.
And let's see,
So
Paula Cabrera has a comment, has a question.
Yeah, the blood sample is not mandatory for the trial. We encourage people to get, because that's what we're looking at to see how it changes. So we encourage to consider. Yeah.
And nor is the tissue requirement required, right?
That's right.
And Justin Floyd, was your comment about this?
Yeah. Can you hear me?
Yeah.
Okay. Hey, Krishna, great study. And we've put a lot of patients on this in our NCORE. So thanks for putting a study out. Pretty easy
Thank
to
you.
accrue to. You know, we just one comment for anybody that's wanting to accrue. We took a approach similar to 1501, where pharmacy builds our treatment plan. So we just had pharmacy notify the physicians anytime a treatment plan gets built for one of these adjuvant or one of these eligible regimens. And then the individual clinicians will then screen those patients for study. So kind of a screening effort through pharmacy based on drug treatment plans was something we found to work, and we put a bunch of people on. So thanks for doing it. And just a comment from us as to how we found patients.
Thank you so much, Justin. That's very helpful. And I'd like to thank your participation from S2013 team.
And then there's one more comment in the chat.
I don't, I believe you do not have to be NCORE site to participate in S2013. All are welcome to participate.
Okay, great. All right, well, thank you. And oh, one more. Oh, sorry.
Yeah, just a very quick question. You said, of course, that they could be on only immune checkpoint inhibitor. There are a lot of approvals now for combinations of checkpoint inhibitors. Can they be on a combination, or it has to be one drug?
Yeah, so study team had future vision that these are all going to come approval. So we left it open. any of the immune checkpoint inhibitors would be eligible to go on the study.
Wonderful.
And the study that Dr. Hirschman was referring to is DIRECT. Its name is DIRECT from Roswell Park for the disparities.
Okay, great. Thank you.
Thank you.
All right, we will now switch to our next presenter. Dr. Vicky Barakos is going to present her cachexia proposal.
Hi, everyone. To those of you who haven't met me, I'm Vicky, and I guess I'm a career interested person in the process of wasting, which occurs to so many people affected by malignant disease. And this has as its centerpiece the wasting of muscle. So skeletal muscle wasting is considered to be the focal point for the adverse outcomes that are associated with cancer cachexia or wasting syndrome generally. So that field has a strong focus on muscle, and I'm going to explain the proposed mechanisms of this wasting syndrome with a view to helping you understand why I think leveraging the data which exists in SWOG 0816 can get us some answers that we presently do not have. So this is an understanding of a wasting syndrome with a focus on muscle wasting. And we believe that it is driven globally by two big things. So the upstream picture is that wasting is driven by a failure of adequate food intake for different reasons, but that there's a second panel and that there is, independent of food intake, a catabolic drive. And that turns on wasting processes in tissues like muscle, and that is attributable to alterations driven by the tumor. So if I could have that next slide, please. Here I have in front of you a cartoon of current understanding of cancer cachexia from a recent review. So what I like to emphasize on it is it has different pieces. So first of all, the tumor, very important as a driver of the wasting process. But in addition to the tumor effects, the tumor's crosstalk with the immune system participates in the generation of inflammatory mediators. So we have tumor-derived mediators, inflammatory mediators, let's say a long list of molecules, which importantly have the capacity to push wasting in two different ways. They can act directly on muscle and adipose tissue to invoke their breakdown through receptors, but they can also act on the central nervous system to launch sort of a second wave of wasting influences, anorexia, fatigue, and also endocrine changes. So this is a conceptual map, but we need evidence to support or refute the relative importance of these different pieces. So related to this clinical trial, there's elements within the clinical trial that we think are potential wasting drivers, particularly of muscle wasting. Number one on the list is the tumor response. So invisibly, a tumor which responds completely would be associated with mitigated wasting, whereas a tumor that simply progresses on the other end of the distribution would drive wasting. Secondly, inflammation, as variously manifested by different individuals and different tumors that they happen to have, is going to contribute variously to the wasting downstream invoked by these inflammatory mediators. So we're interested in knowing clinically whether indices of inflammation are associated with the wasting process. And then the endocrine piece, which is also included in this SWOG clinical trial, our understanding of the endocrine piece of wasting has to do with gonadal hormones and the sexual dimorphism of testosterone as a driver of muscle mass. So those facets are also covered in this clinical trial. So could you change the slide for me, please? So here's a way we articulate the hypothesis that we applied to this trial or data set. And it is that the progressive loss of skeletal muscle and secondarily fat mass, so this loss, defined as cachexia, is induced by a variable combination of inflammation, disease progression, and treatment-related toxicity. So that's the notional idea of what might be going on. Our aim would be to test the association of muscle loss as our primary outcome. So different patients will lose muscle or will have lost muscle over time in this clinical trial on the treatment that they were on. That could be predicted by patients' age, sex, and sex hormone status, represented in this investigation by testosterone, FSH, LH, and estradiol levels. So those are known modifiers of muscle mass in male and female persons. Further, that inflammation could be associated with muscle loss over time, and that is represented in this clinical trial by baseline values of erythrocyte sedimentation rate, albumin, and white blood cell counts. We think that muscle mass could change over time in function of the tumor stage, size of measurable disease as greater or less than 10 centimeters at baseline, and then its response to treatment over the course of the treatment plan used in the study. And lastly, there are a couple of treatment toxicities that prominently are known to push wasting, and these would be severe infections and neuropathy. Both of those things are characterized outside the oncology literature to promote muscle wasting and weakness. Can I have that next slide, please? So here I'm just going to tell you about the design of the clinical trial and what we would be doing in relation to our primary outcome measure. So the participants in this study included over 300 initial participants who then went on to have their first 2 cycles with ABBD, at which point they were restaged and followed by PET-CT imaging. So we have a CT imaging interval over which time for each individual we can detect the change in muscle. This is muscle cross-sectional area. What you expect to see in this period for individuals in a sample would be represented by a waterfall plot. So you have amongst individuals, typically with a given cancer treatment plan, you have a wide distribution. Some people maintain or gain muscle and others lose it to mild, moderate, and even severe degrees. So the intention here is to relate this dependent variable with the covariates, treatment response, treatment toxicity, hormonal status, and inflammation. Present status of this right now is I'm working and getting some great input from Catherine Guthrie and also from SWOG statistician to finalize the exact statistical analysis for this investigation. And then if you go to what I think is my last slide, or second last, I just remind you that I'd like to link in with other people doing imaging so that we can hope to concord and harmonize our respective efforts. And I guess that's my next last slide. If you could change that one more time. Can you advance the slide, please? I just want to close off by presenting to you that we really hope that this investigation will help us get some clarity on some of the factors, some of the clinical factors that were rigorously measured in a clinical trial, how they relate or potentially relate to the progression of cachexia, which leads us forward in dimensions that we do not presently understand. Thank you so much. I'll stop there.
Thank you, Vicki. An important study, and I think important to note how so much work can be done leveraging studies that were previously opened related to a different research question. So this is an ancillary study proposed to an already completed trial. I have a quick comment, unless anyone else does. And I know we discussed this via email, but in my naive review of the literature, cachexia can also lead to treatment toxicity and poor outcomes. And so I'm intrigued with sort of the bidirectional associations that might occur with, maybe not with a tumor response, but maybe between inflammation and toxicity with cachexia. Your thoughts on that?
You're absolutely right. There is a bidirectional thing. So if you, simply have a terrible toxicity like nausea and vomiting, that will prevent you from eating, and then further the wasting process. And so treatment toxicity causes cachexia, but cachexia causes treatment toxicity, I think, in the following generally understood sense. The body composition of the person, or different individual persons, is widely variable, but that body composition isn't taken into account in dosing paradigms. So we flat dose, we weight dose, we BSA dose, we dose to renal function. Cancer therapeutics are dosed in different ways. And in some individuals, the dose that they get in the standard of care may interact with their body composition in such a manner as to give them a relatively high AUC. So I think that the best understanding of how cachexia, or let's say more broadly, body composition relates to treatment toxicity is in studies where pharmacokinetic data are available. I think they're going to bring forward the best kind of evidence. We need to interpret those data, and down the line, you might think that would lead to dosing that might be adjusted in certain persons at risk because of their body composition. If I could example that, I would say, imagine if you dose a very, very heavy person who has very bad sarcopenia, they will get a very big dose, but that might end up in a relatively small metabolic compartment, which is the place where the distribution, metabolism, and elimination of the drug takes place.
Wonderful, thank you. Any comments from the audience or online? All right, Vicki. Well, we hope to move forward with the finalizing the statistical analytic plan, and also learn more from imaging in regards to obtaining the CT images. So more to come, hopefully, in the next couple of weeks.
Great, thank you. Enjoy Seattle, those of you who are there.
All right, thank you.
Thanks, Vicki. Okay, I just wanted to give a quick update on the COG-led cross-network trial that's in development, looking at GnRH analogs for protecting ovarian reserve in AYA cancer patients. So this is a randomized controlled study that looks to enroll 250 female subjects under the age of 40 with newly diagnosed cancer, and the planned treatment that includes alkylating agents. It's going to be basically testing the efficacy of GnRH analog on preservation of ovarian reserve with stratification by age at time of randomization. The main primary objective is to compare ovarian reserve as measured by AMH at 2 years post completion of chemotherapy in this population, based on randomization with or without the GnRH analog. There's also a number of secondary aims for this study, including longitudinal change in AMH by randomization status, comparing estrogen deprivation symptoms, menstrual patterns, and quality of life in the 2 study arms. Also looking at a high-risk genetic profile for premature menopause and looking at that and changes with AMH over time. as well as to hopefully establish a cohort of female AYA patients treated in this manner that can be followed long-term to study reproductive health concerns and outcomes, including fertility types of outcomes. So just a quick update on where this stands. I kind of stole and modified this slide from Dan Raz because I liked it so much. So there has been support from the committees and approval by the COG Executive Committee of their one-page concept. I've seen a very good draft of the full capsule, which is almost ready with a few things to be hammered out. So this is moving along, and hopefully we'll continue to hear more.
Is there any issue with the ovarian function suppression being covered by insurance, or how is that being handled for this study?
So that's part of the negotiation right now, is figuring out which product to use and seeing if we can get support. There's talk about using triptorelin, which has a 6-month formulation, which would basically be a one-shot deal for most of the patients who wouldn't be getting more than 6 months of chemotherapy. So that's hopefully, but no, I think it would have to be funded by the study.
And then Rachel Young has a question on the chat. If you want to unmute.
Yeah, I was just wondering if there was a particular reason why you're excluding breast cancer patients. And
yeah, so SWOG had led SO230, which was the randomized controlled trial in triple negative breast cancer, showing the benefit to the GnRH analog in this population, and multiple guidelines recommend it for that population already. So this is really to get at the other populations, because the literature is much less convincing for lymphoma and some of the other disease types.
perfect, thanks.
And then, are we planning to open at international SWOG centers? I don't see why not. I don't know if anybody from who knows more about operations than I do, but I don't see a reason why it couldn't. Okay, so whether we could get the drug to the sites, I guess. So we shall see.
Okay, well, I think that, oh, yes. So we have just a couple minutes to open this up for your thoughts or feedback over a discussion that was initiated a couple months ago with NCI, and also continued last night about, and also heard this morning from Emily, as to leveraging study participants that are enrolled in clinical trials and reconsenting them for follow-up for either additional studies and into a long-term survivor cohort. So what we learned a little bit last night is that over the past X number of years, there are about 72,000 patients that have consented to being recontacted. However, it's not as easy as it sounds. There can be challenges with how to contact them at the various sites across the country, but we don't want to abandon it yet. So we're looking for comments or feedback on this. And then separate but related, thinking about tweaking perhaps a new approach going forward with new studies that are enrolling patients and how to consent them into survivorship studies and or alumni groups where there's a bi-directional engagement and outreach. So it's not just study involvement as well. And
so just to comment on the current state, we now have on most of our trials a place where participants can check a box to agree to be contacted. And we've seen the wording a couple different ways, one by my study doctor or someone from the study team, and another saying someone from Southwest Oncology Group may contact me. The problem is we don't keep contact information on patients, and there are HIPAA issues with that because SWOG only receives de-identified information. So that's kind of one of the challenges that we would be facing. So we are interested in both looking at ways to overcome this challenge in patients who've already agreed to be recontacted, but also trying to get together a little committee to think about moving forward how we might better consent patients to be recontacted. And I don't know, Melinda, if you want to talk about this idea of an alumni group for our SWOG participants, which I thought was really interesting.
Yeah, from a morning discussion with Mike Fish, so that would be great if we can get a committee together over the next couple of weeks. But also welcome input from our patient advocates, from our community advocates, and also thinking about, it always helps to move these things forward when you actually think of a potential hypothetical or real study, and how you could use the existing patients or going forward new patients.
Yeah. And just like SO221, which was a large adjuvant breast clinical trial where patients were randomized to 2 different fairly intensive anthracycline and taxane based regimens, looking at different scheduling, and everybody got the same drugs. And in that trial, about 80% had consented to be recontacted. In our database, about 1,900 of those who had consented are listed as alive, although the median time from last contact had quite a large range. It's not clear the logistics about how you would get at those patients. But that was just an example of one study, and obviously there are many studies in SWOG. So we'd really like people to start kind of thinking out of the box about how we might use these cohorts of patients who have, for whom we have a lot of detailed treatment and initial toxicity information and other information.
And just looking at the comment in chat here, asking about, don't we maintain contact info for patients enrolled in trials when there are long-term unexpected toxicities or complications of treatment? So this is sort of after that trial has completed and they're no longer being followed as a part of that trial. And so this is sort of above and beyond that, if that kind of answers your question. Banu.
So this is the questioner, Banu Symington. I guess I thought we maintained some sort of contact if there is a long-term unexpected complication of treatment. So we could call them and say, hey, we didn't know this was going to happen. And I guess I was naive in that respect.
If it's not a study aim, like an aim 3 or 4 to follow them at 1, 2, 5 years out, then when the study ends, it ends, and often many sites have to then close that out in clinicaltrials.gov or other places, and so they're not continued to be followed in that regard.
Yeah, I think Catherine Guthrie could speak to that as well.
Yeah, I'm the statistician on the committee. I just wanted to clarify logistics. So the SWOG Statistical and Data Management Center does not keep patient contact info. So in order to contact patients, we have to reach out to sites. If a site wants to report a patient's long-term adverse event, they can do that, but we still do not have that patient's contact info. We would have to go through the site. Yeah.
Kathy, this is Kathy Cruz.
So I think that in addition, if we could figure out the logistics of being able to store that information either securely centrally through the data center or at the individual local sites, I think we should see this as an opportunity not just to potentially recruit to long-term survivorship studies, but also think about how we can use that to keep participants engaged in the study itself, help with retention. And then there's also a lot, because there are a lot of translational studies that get built in, and when there are clinically actionable data that could potentially be returned to the participants, or even, like patients enroll in a large adjuvant trial and the results get published several years later and they have no idea what the results of the study. So I know from the CIRB perspective, we're very interested in making sure those participants are engaged and know what the results of the trials are that they participated in. And then also thinking about, if there are opportunities to do additional studies on late effects.
That's exactly right. And that's the conversation that I had this morning with Dr. Fish about that, in that it shouldn't just be about potentially enrolling them in survivorship studies, but the engagement, keeping them engaged as to findings of studies and whatnot. So I think there are multiple pillars of activity that can happen.
This is Catherine Guthrie again. I hate to be wet blanket, but I just want to make clear before people get too excited. Statistician's job is to bring us back down to earth. Sorry. But so there was actually a really great effort made, mostly at SCMC, Stats and Data Management, where there was a whole website built for former SWOG patients, and they could access their records so that they could understand what their treatment was. They could get results of the study years later. All these things were in development, and it just turned out to be a huge resource issue for us to keep that up and to try to reach out to former patients so anyway, so it's been thought about. Maybe it could be rethought.
And it sounds like the NCI has an interest in doing this across all the cooperative groups. So there may be resources that might.
Yeah, I think that's different than thinking about it prospectively in the modern era, right? So that's like a different effort from the past that really relied on patients to reach out. And I think that's different than using current models going forward and engaging patients up front, figuring out like how to have direct contact information with SWOG, whether it's through their social media platform, email, phone number, all of that, is very different than reaching out to sites, expecting sites to contact the patient, and maybe you could do that for one trial, but it's hard to do it for 70,000, whatever it is. So, I think that we're in a different era. We have central IRBs now that, as opposed to going to each individual IRB, and we're better positioned to understand, how to leverage current HIPAA, current IRB rules, and better in patient activation than existed 10 or 20 years ago.
Thanks. I think on that note, we'll end, but if anybody is interested in participating in a group to further discuss these issues, please feel free to email Melinda or myself.
Great. Well, thank you so much for coming this morning, and have a great rest of the day.